Good morning, good afternoon, good evening to everybody. Thank you for attending our session. I'm Dr. Mary Cardosa, pain specialist from Malaysia, and I'm also going to talk about pain education in LMICs, focusing on my experience with this in Southeast Asia, as well as some of the initiatives run by the International Association for the Study of Pain, or IASP. These are my disclosures. I do not have any conflict of interest for this lecture. So in this talk, I will talk about the need for pain education and the challenges faced in LMICs, some pain education initiatives as listed here, the impact of this, and what else we need to do and how do we move forward for the future, questions for the future. So the need for pain education in LMICs has been highlighted since the beginning of the century. The IASP Task Force, Developing Countries Task Force, led by Sir Michael Bond, published their report in 2007 stating that undergraduate pain education is inadequate and specialized postgraduate training is variable. Lack of education was identified as the biggest barrier to good pain management in developing countries. And more recently, Wayne Morris and Claire Rose, in a review of pain management in LMICs, have stated that apart from advocacy and improving treatment availability, education is key for improving pain management in LMICs. This was reinforced by the IASP Global Year on Excellence in Pain Education in 2018, where one of their fact sheets stated that the way forward to improve pain management in low-resource countries is advocacy, education, and training. So what are the challenges in providing pain education? Limited resources, of course, is highest on the list, not just from the viewpoint of funds, but also space and staff. Staff have a very high work burden often, and service is always prioritized, not education. Pain management itself is often not a priority, and many countries do not have an official policy or national policy on pain management. So there's limited support and no allocated time for staff training. In addition, pain education actually has many target groups. Healthcare providers themselves consist of physicians and non-physicians and range from students to specialists. We also need to target policymakers, and we cannot forget patients, not just as recipients of pain education, but also how to incorporate the voice of that person with lived experience. I've listed here some pain education initiatives that are run, I think, in most countries, conferences, workshops, training at undergraduate and postgraduate level. But for this talk, I'm going to focus on the initiatives by WFSA and IASP. World congresses like this one are great, not just for updating your knowledge, but also for networking purposes. And so I think it's important for us to continue the programs that enable people from developing countries to attend such congresses. Educational grants for running educational programs in developing countries are also important. The IASP has an annual grant for this, but because of limitation of funds, we have now been focusing on awarding grants to countries where grants haven't been awarded in the past, and also to low income and low middle income countries. The other four programs I'll be talking about in the next few slides. So pain fellowships, WFSA as well as IASP has pain fellowships all over the world. The one that I know best, and it's a joint fellowship program, is at Siriraj Hospital in Bangkok, Thailand. This is a one-year program with 2 fellows per year and aims to give practical training in pain management to doctors from resource-limited countries and to develop these experts who will then go home and set up services and become trainers in their own countries. So far, 24 fellows have been trained from 9 different countries. And what's the impact of this? We don't have official, but reports back from graduates show that it is an effective program, and they do a lot of work in their countries after returning, both in terms of service provision as well as education. EPM is all over the world, yes, but in Southeast Asia, we have run it in most countries. Different kinds of workshops are available, as you know, and but the uptake, what I wanted to mention here is that the uptake is different in different countries, and I think that the difference is whether you have a local champion or not. In Malaysia, for example, we managed to incorporate EPM into our Ministry of Health National Pain Training Program under the Pain Free Program. In Hong Kong, the training is run through Hospital Authority in HA hospitals. And in the Philippines, it's been taken up by the Philippine Pain Society as a regular program, and so it's run regularly all over the country. But in countries like Cambodia, Laos, Vietnam, where there are no pain societies, there is very sporadic and variable in terms of frequency. What's the impact of EPM? So Gertrude Maroon from Papua New Guinea has published this article talking about the impact, and she mentioned that in terms of outcomes, there's modest improvement in knowledge as evidenced by the difference between pre and post-test scores. But more importantly, what are the behavioral changes? These were assessed by a qualitative study and showed that the increased knowledge did lead to change in clinical practice, increased use of multimodal analgesia, education to other healthcare professionals, and regular use of RET. This article prompted letters to the editor from Nepal and Rwanda, and both have said that EPM is something that can be used can make a difference to pain management. In fact, the article from Rwanda said that it will change pain management in the world. IASP pain management camps are run both in Southeast Asia as well as in Latin America. And in Southeast Asia, we have been running it in conjunction with the Biennial Conference of the Association of Southeast Asian Pain Societies, or ASEAPS, since 2011. And we have trained a total of 145 people from 16 countries. It's a 5-day residential course and covers essential elements in pain topics, mainly focusing on day-to-day clinical practice. So these camps, we always have a lot of fun, but it's very labor intensive and also costs quite a lot of money. What is the impact? We did a survey of graduates from the camps, and we found that it was effective. All of them had increased knowledge about pain and, importantly, increased involvement in clinical pain management and pain education in their countries. And also, I think very importantly, many graduates helped to set up local pain societies where these didn't exist, for example, in Nepal. The last but not least project that I want to talk about today is the IASP Multidisciplinary Pain Center Tool Kit. This aims to provide local clinicians with the knowledge, skills, and training to establish multidisciplinary pain centers based on interdisciplinary models of care. Our target countries are Indonesia, Myanmar, and Vietnam initially, but we hope to be able to roll this out to the rest of the world. The premise of this is that in providing, in setting up a multidisciplinary pain center, this would then be able to provide effective evidence-based treatment to patients in pain in that country, and also act as a center for training for other people, other clinicians in the same country. So we have a manual which is available on the IASP website that has 5 chapters. We start off with the need, how to make a case for setting up an MPC in your country. And we have things like how to use the global burden of disease data, and so on and so forth. We have then practical points about personnel, services, facilities, evaluations, and measurements. And last but not least, we have case studies from Malaysia, Philippines, and Thailand. Importantly, we want to talk about recommended training in this manual. We have 3 levels: entry, intermediate, and advanced. Entry level, we recommend EPM for everybody, not just those running the pain services, but also other staff in the healthcare facilities. intermediate level, we have developed these modules for this, and we focus on teaching pain self-management skills and practical points on setting up multidisciplinary pain centers. We also have more details than EPM about managing acute chronic cancer neuropathic pain. Advanced level training we haven't done very much about, but we do recommend that there are a few people from each center that goes for advanced training. So far, we've carried out 2 training programs. In Myanmar, we did an in-person training in 2019 with 5 days with 30 people. In Indonesia, we couldn't do this, so we had to convert to virtual, and we did it just earlier this year with 50 participants and 8 4-hour sessions. And we thought that it actually went quite well, although we did have to do a lot of work to modify the way that we did our teaching and training. We're going to repeat this in Vietnam next month, and we have extended the time because of the need for translation. So in future, we plan to integrate the toolkit curriculum with the IASP Pain Camp curriculum. And we also think that this manual and training can be applied in other LMICs. So the training material, the manual is available on the IASP website, as mentioned earlier. We need to look at translation, and we need to look at training of trainers. So after all these, looking at all these different educational activities, which actually take a lot of resources, we need to answer some questions. Are we making a difference? Is there an improvement in pain management in the country? Because that's really what we want to achieve with pain education. What should we focus on? Training of individual, local champions, and hope that they take it away and do the best in their own countries. Basic pain education for everybody, so that pain management in general will be better. We need to train, we know, not just knowledge, but skills. But what kind of skills? Currently, a lot of skills are focused on procedural skills. What else do we need to teach them about? And I think we need to empower local pain clinicians. I mean, the reason why we set up the multidisciplinary pain toolkit was because we thought that we need to empower local pain clinicians to set up services offering evidence-based treatment. Moving with the times, we need to move, we know, to online learning, but what should we do? Self-learning versus webinars or workshops? And how do we use social media? For example, the Siriraj graduates have a WhatsApp group where they discuss cases. Other questions, what about patients and people with lived experience? How do we include them in this whole process of education? And what about bigger issues and advocacy? Should we get involved, or should we leave other people to do it? So I talked about that because of this article by Roger Gook and Pong Paradi talking about pain in low resource settings and saying that some barriers can be addressed by education, but others will require advocacy at government level. And only when we tackle these problems will the considerable neglect of access to effective pain treatment in LMICs be lessened. This is reinforced by Cynthia Gore, who has done a lot of, in her article in 2018 as well, who has done a lot of training on pain and palliative care in Asia Pacific region. She stated that providing training on its own, particularly one-off training, will not automatically lead to services being established and patients being cared for. We need to include advocacy. We need to be recognized by peers. We need to make tools and drugs available. We need to have, for sustainability, a national policy. So I leave you with these concluding thoughts. Personally, I think we need to continue our efforts with pain education in LMICs, and this collaboration between organizations and individuals from high-income countries and local champions in LMICs, I think is great and should continue. Education must be at different levels. EPM provides the basic education, and I don't think we need to revisit that. I think we need to just roll it out to as many people as possible. Intermediate training, I think, is needed, and I think that what we have developed with the Pain Toolkit can provide this. But we need to think about whether we should also be developing more advanced modules on specific topics. We need to share resources globally, online learning, use of social media, as I mentioned earlier, and translations. There are some unanswered questions. How do we incorporate the lived experience? What about certification? What can people do after attending these courses? How do we ensure quality control, not just of practitioners, but also of trainers? And last but not least, what is our role, WFSA and IASP? So thank you very much for your attention, and I hope we can discuss some of these things in the Q&A session.